Yeah, 76. Plan, and she can read it all. We don't have lunch about it.
Where you are.
There,
Are
you ready?
I just wanted to.
Yeah, absolutely. Good afternoon. I'd like to call the March Public Health and Human Services Committee meeting of the Commission to order. Certainly want to welcome all of you who are in the audience that are visiting with us in person, and certainly those who are online this afternoon. We'll start off by asking our committee members to introduce herself at this point. So I will move to my left and ask Commissioner Powell, please introduce yourself.
Good afternoon. I am Mecklenburg County Commissioner Elaine Powell, representing North Mecklenburg, Huntersville, Davidson, Cornelius, North Charlotte, and all of the unincorporated area. Welcome.
Thank you. We have a guest commissioner with us. She should be homesteading by now since she visits so often. I'd ask our colleague to introduce herself.
Thank you, Mr. Chairman. Susan Rodriguez McDowell, elected by the people of District 6.
Thank you. My name's Arthur Griffin, and I have the opportunity to chair this illustrious committee as your county commissioner at large. Next on the agenda would be the approval of our minutes. We'll have to delay that until we get the third member of the committee. We'll do this after the presentations and after the Q&A discussions. We now go to our guest and our staff. So let's start with our senior representative here. Mr. Trotman, please introduce yourself. We'll go around the table and also introduce other members of the staff that are present. All right, Anthony Trotman, Deputy County Manager.
Good afternoon, Kim Henderson, Director, Child, Family, and Adult Services.
Good afternoon, Reynard Washington, Public Health Director.
Good afternoon, Taya Cruz, Assistant to Deputy Manager.
Afternoon, everybody. Robert Nesbitt, Chief of Staff for Health and Human Services.
Good afternoon, Yolanda Griffin, Director for Department of Community Resources.
And we have some wonderful staff and guests with us, I believe.
Michelle Ivy, Chief Program Officer from Daymark Recovery Services.
Good afternoon, Michelle Hunt, Executive Director for the Steve Smith Family Foundation.
Ashley Gold, Senior Director of Crisis Services for Daymark.
Hi, I'm Abby Wyatt, the Livable Met Coordinator.
I'm Megan with Coordinated Entry.
Erin Nixon with the Continuum of Care under Community Support Services.
Kenya Dawson, Community Support Services, Housing Manager. Hi, Karen Pelletier, Mecklenburg County Community Support Services, Housing Innovation and Stabilization Services.
I'm Alex Burnett with the Public Information Department. Where does this live?
Thank you all and welcome for your presence this afternoon. We have two outstanding and innovative presentations this afternoon. One Community Support Services, Housing Innovation and Stabilization Services, and one that one of our members really wanted to have on the agenda, and that's the Smith Family Behavioral Health presentation. So I hope she's watching. I'll go to Mr. Trotman, our Deputy County Manager, who will introduce these segments. And if at all possible, colleagues, it's only a couple of us, 3 of us, but let's try to keep the same format we usually keep, and that is take your notes, and then we'll follow back with questions after the presentations. Mr. Trotman.
I'm excited to bring up Karen Pelletier to the podium. She is known in the community as Karen from the county.
Karen from the county. All righty.
And she has some great data and information to share for our housing and homelessness update.
Thank you, Karen. I can see you.
Okay, I feel unusually short. And I'm still waiting on the t-shirt that says Karen from the county, just. So.
It's on the way.
So thank you, Commissioner Griffin, Deputy County Manager Trotman, the rest of the Health and Human Services Committee and staff. As you know, I'm excited to be here today to talk about our impactful and innovative work that's being done in Mecklenburg County in solving for homelessness. I want to stress the word innovation in our name. When we rebranded ourselves last year from Homeless Services, innovation was really the cornerstone of the work, that we have the opportunity to work in a community and be supported in a community, to be able to be innovative and not stay just rigid on what we need to be doing, but being able to be creative and come up with solutions. Homelessness is complicated, and it's going to take innovative solutions to really solve for it. Before I get started, I do want to take a moment to introduce or reintroduce, I guess, the HISS, we call ourselves HISS, leadership team. We have with us today Megan Coffey, who's the manager for coordinated entry. We all know about coordinated entry. We have Erin Nixon, who's the manager over the Charlotte-Mecklenburg Continuum of Care, and then Kenya Dawson, who is over our supportive housing programs that the county provides in our community. And so it is due to their dedication, their work, and just their curiosity on getting it right is really, I have the privilege of sharing the work that really they do the most of doing that. And so just an actual shout out of the phenomenal women during Women's History Month too.
It did skip on me that all of the guests over there, with the exception of one, was all ladies.
It's wonderful.
I love it.
So just in level setting, Community Support Services mission is to transfer lives and community by supporting veterans, ending homelessness, treating substance use, and preventing and intervening in community and domestic violence. And really, I believe our division does touch on each of those. So today I am going to talk about 3 of these pillars, starting with our prevention piece. Each of these projects are collaborative and strengthen the impact at both the direct and system level. They are projects that are a result of our ability to leverage existing resources, maximize our county investment, and bridge relationships with a variety of local and national partners. Housing insecurity is a board priority and the focus of our division. None of this happens in a silo, and I will also connect on some level your other board priorities such as educational attainment, racial equity, and workforce development. I'll start with prevention, as intervening and preventing homelessness is really the first place to start in solving for homelessness. This work elevates the impact and expansion of coordinated entry last year through ARPA funding and our partnership with a national nonprofit, Community Solutions. Next, I'll share data and stories about our street outreach team that was created to encompass the entire county and not just uptown, because as we know, we have unsheltered neighbors throughout our community from Pineville to Davidson, Still Creek to Mint Hill. And we even know of encampments even in the South Park and Ballantyne areas. This team is engaging and intervening with people living outside who are disconnected from services. and really getting engaged better to services and other resources. And I'll also give an update on the work that Black Love has done in opening up a new day service center in North Charlotte. And lastly, I'll share more about more tangible solutions when it comes to housing stability, and that's the expansion of affordable housing, both for our aged out youth from foster care and 2 new housing programs that are underway. So, research indicates that a leading indicator of needing emergency shelter is a previous episode of homelessness. That's why I'm starting with prevention. This is one of the reasons we wanted to shift our focus at coordinated entry from beyond being that portal to emergency shelter or really getting on a shelter wait list, but really being able to help problem solve and provide that assistance to people who might otherwise need emergency shelter, but could not need shelter if they had some kind of financial assistance and short-term case management. As the onset of COVID, we began convening an ad hoc committee focused on developing stronger strategies to prevent homelessness, and that momentum grew as the impact of the eviction moratorium grew. Thanks to county ARPA funding, we were able to almost double our capacity at coordinated entry by adding 4 staff to better meet demand and to allow more thoughtful engagement. Staff continue to balance the duty to serve and problem solve with people in crisis, while also managing our high call volume and the number of walk-in people in need at 5 different locations throughout the community. We've also been able to better train partner agencies to conduct coordinated entry themselves to prevent that extra step for people who are in need and in crisis. Instead of having to reach out to coordinated entry, we have more providers in our community that are doing those assessments, entering people in HMIS and helping to get them prioritized for other resources. The collective nature and curiosity of the group got the attention of Community Solutions, and we were awarded $200,000 earlier this year to provide direct financial assistance to people who were in need of assistance. We implemented a new training tool that helps coordinated entry staff identify and target people who are most vulnerable and who otherwise would be entering into homelessness. Community Solutions is now helping guide our journey and developing strategies related to homelessness prevention. They've invited us to actually be part of a national learning community to meet with other people in the same space in other communities like Nashville, Jacksonville, Florida, Phoenix, Arizona, and other cities similar to Charlotte, and help us learn from what they are doing and for us to share what we're doing to, again, to better align resources. Although eviction prevention assistance continues to be the primary request, we really hope to start identifying assistance opportunities that are even further upstream. We're really trying to even prevent people to start preventing them from having to deal with the stress of eviction, that we are really wanting to figure out ways to better serve people upstream to prevent even the trauma of possible displacement. The Charlotte-Mecklenburg Continuum of Care provided funding to train our coordinated entry staff and some shelter staff on helping people become more experts in talking about housing problem solving, being able to have different kinds of conversations with people to really help them think more creatively about homelessness, housing prevention, what are other resources that they could have. We've also been able to work with the City of Charlotte and Carolina's Care Partnership in connecting people experiencing financial hardship who are living with HIV or AIDS and providing them with up to 21 weeks of rental or mortgage assistance. This is a new initiative, but again, that's building on the work that we're doing. More people are hearing about what we're doing and are wanting to connect to the success that we're having in our community and to broaden that. So in November is really when we were able to start getting the services out into the community. People are accessing it through coordinated entry. Since then, we've helped 53 households. That's over 100 people. We've served families that are 8 and 9, sized with 8 and 9 people in them, and being able to keep people in their housing. Again, most of this has been eviction prevention, but we've been able to intervene prior to even people going to eviction court. We do also know that we're paying rent arrears, we're helping with security deposits, utility payments. We've also diverted 84 households from shelter. So those are individuals that are literally homeless and don't have anywhere to go, but we've been able to talk with them, help them establish with families and friends either in Charlotte, or been able to reconnect people back to like their community. If they were from another state, helping them return to that state where there are natural supports for them, perhaps a job waiting, family and friends, people that they could live with that aren't in crisis. Again, we really are trying to figure out ways, because we know that people don't leave eviction court per se and end up calling coordinated entry, that people really end up in our shelter after they've run out of relationships, not necessarily resources. So again, with Community Solutions, we really hope to come up with even greater solutions to prevent homelessness in our community. So a little bit of about what coordinated entry is doing, just so you can see the impact. That we know that we're receiving about 1,400 calls per month just to our coordinated entry hotline. Now, that is a duplicated number, but we know that it is still pretty close to 1,400. The continuum of care helped us improve our phone system. So we are going to be able to start sharing better data on the actual number of duplicated people that are calling, the length of time, the response times for people. We are going to be able to start measuring that better, but we know it's approximately 1,400 calls per month. Over the phone, they're conducting over 1,100 coordinated entries and assessments, and that's that full assessment that is learning more a little bit about their history, their housing situation or homeless status, and then working to then prioritize them on our by name list to hopefully provide them a housing resource. In addition to that, we have over 1,800 on-site connections, and that is just through our 5 different spaces that we have at both CRCs, at Roof Above Shelter and Day Center, and at Salvation Army Shelter. So they're staying rather busy. That's probably why Megan's a little stressed out even being here, because she knows there are people waiting in need that we need to call back. Speaking of which, the number one complaint we probably get, or you all probably get, is from about coordinated entry, is that you have to call and leave a message and someone will call you back. We know that is extremely stressful. We wish we could do better, and we are doing better. The expansion of our ARPA funded staff has helped reduce that time in the callback. We do work to try and call someone back within that next business day, but it's purely because of that call volume and the number of walk-in staff that prevents us. In an ideal world, we would be able to have someone call and someone answer. It's just the call volume is just far too high for them to be able to do that successfully. Street outreach. Very excited about the share about here. Because if we learned anything during the North End encampment work, is that we know that people living outside are very disconnected from services. And so I'm proud to say that the Board of County Commission and the County Manager's Office understood that gap and knew that we needed to intervene and invest. These investments, currently funded through ARPA, are not just about better serving who are most vulnerable, but also we were able to invest in a grassroots organization who has the passion and commitment for the work, but also, and most importantly, the trust of the people that we're trying to serve. Hearts for the Invisible was awarded funding in May of 2023 to develop a multidisciplinary team and strategic approach to street outreach throughout the county. They're considered the lead agency when it comes to street outreach, and has really worked in partnership across our community with both with the city, with other nonprofits and grassroots organizations to really map out where resources are and which group can best intervene. They have a referral form that people can fill out online. If you see someone who may be living outside, that you can make a reform through there, and they kind of farm out where those resources go. It's open up, it's right on their website, and it's got a very pretty Mecklenburg County logo on there, because all that funding and all the work they're able to do currently is funded through Mecklenburg County. So the team has served over 300 people since May, 80 of whom are children. We are seeing record numbers of children living outside. This past year, we have worked with pregnant women, including 2 newborn babies. That one baby was actually born outside last month. So we are seeing more and more families, and without this resource, we wouldn't have been able to even know that they were outside and be able to connect people to services. Hearts for the Invisible has received training from Youth and Family Services on what to do when they are interacting with families outside. How are they better connecting people? How are they making CPS reports if that's the case? And how are they making that better connection to emergency shelter? A large percent of the people that they're working with report mental health and/or substance use disorders. They have extensive histories of trauma. Many are young adults and women who are also reporting being trafficked. This resource has really been a missing link in a very complicated system, and is leading to positive outcomes in people getting inside, into shelter, into housing, into treatment, and into our hospital system. The BHUC, or the Behavioral Health Urgent Care, has been a key partner with them. You'll hear more about them later, but they have been a true resource for Hearts for the Invisible. Emergency shelter, or exits, excuse me, to emergency shelter and permanent housing are the key exit destinations. And the team has assisted 125 people to shelter, although some of them have returned to outside, but they are at least coming in and trying to get connected to resources. 52 people have moved to permanent housing, and 5 have either moved to some sort of substance use or mental health treatment. And then building on the success, the city of Charlotte has recently awarded this organization more funding to focus just primarily on that uptown area. Another wonderful grassroots organization in our community is Black Love Charlotte. They were awarded funding just last month through our county ARPA funding. They're currently doing renovations to open up a day center on North Graham Street. This will be an expansion of our current services for people who may feel that don't want to access resources at Roof Above's Day Center. They'll have more psychoeducational groups. It's a coordinated entry site. They'll be able to problem solve folks. They have a food pantry and other resources to meet people's emergency needs. And so they're very excited. The grand opening currently is scheduled for next month after the renovations, and they're already up and going on some level, but their official grand opening will be in April. So this again is another great investment on how we're helping our grassroots organizations who are very well established in our community and our homeless system community to better engage to the broader system and really be able to invest better in these organizations that have the trust of the people that they're serving. And then lastly, these are the 4 housing stability, under housing stability, our 4 new housing programs, or kind of realignment of some of our housing programs that we have. Oftentimes we have youth in our foster care system that when they turn 18, often leave our foster or child welfare system and unfortunately end up in our homeless system. And this is a national phenomenon or a national issue. That's not just something that's done locally. But again, in understanding that there's a gap that needed to be filled, the board and the county manager's office allocated $1 million to help us start solving for that and fixing that gap in that system. And so that was allocated last year to help us develop supportive housing to help these the unique needs of these young adults. We immediately began working with First Place for Youth, an organization who's found great success in serving this population and who's yielded great outcomes in creating stronger educational attainment, employment, and housing stability for vulnerable youth. Through a request for proposal, the Relatives was awarded the contract, and together with the Department of Youth and Family Services Division, the program launched earlier this year. And it felt like slow to get started, but just since we've been able to get going, we have 15 youth that are set to be housed before June. Seven have already moved into housing. We have the other 8 will be housed in the next year. We've already identified the youth. And then starting in July, we'll be able to add 15 more youth to this project. And so this is really about how we're developing system change for folks and how we're really able to have that resource for young adults that don't have a place to go, that are precariously housed, that are oftentimes being exploited, and being able to have those additional resources to really finish high school, start college, start work. 2 of the young adults that we've moved were parenting youth. So when we really think about the trajectory of youth without this resource, this is really, I feel like a game changer for so many of truly our children, because they've been emancipated from our county. Also with that, I want to just also thank LaShonda Hart. I know she's not here, but I want to thank her, LaShonda Hart and Ascend Properties too, because of the partnership and what she's doing on expanding affordable housing and our naturally occurring affordable housing, those NOAA projects, that we've been able to partner with Ascend Properties and his team, so the Mark Etheridge and his team, on the properties that he has currently invested in. Those are where our young adults are now living. So they're able to live there for free. They're able to save whatever their rent portion would be. So when they leave this housing program in 2 years, because it's a 2-year program, they'll have somewhat of a savings account going for them, and they'll be able to maintain in that unit post-exit. So they will live in a community that maintains their affordability. So it's really exciting about that collaboration. Our housing stability as it relates to our domestic violence, we have our Housing for Good family that we've really been able to maximize both our county investment and our COC investment, and how we're serving families who have fled domestic violence. Their lethality has reduced, and now they are working to return to housing, return to the job market, be settled. And so we have been working more with them. In these last several months, we've been able to maximize that resource because it had been going underspent. So we know that we maintain a list of kind of who's next. These are each programs that people can stay in up to 2 years, and they provide that support services. And so we have the 2 programs. One is funded through the county, and one we have funded federally through our COC and HUD. We've developed a prioritization process to, again, really help make sure that we're helping the most vulnerable. And then building on that work, HUD has also funded us an additional coordinated entry social worker who's housed between the Survivor Resource Center and Safe Alliance, and is working specifically with people who had been impacted by domestic violence, helping them problem solve their housing crisis, and then helping them return to the community. And so this, again, this is the first one that we've had in our community. This has been a resource to have someone who is knowledgeable about the impact and the complexity of domestic violence, understands the safety planning and the needs of people who are returning to the community without the protective nature of shelter. And so this provides this opportunity in our community. We're also working to explore other best practices to really help improve our housing for families and individuals who have fled DV and that are returning. Again, we understand that that is a gap, and we want to learn from some national best practices. And then lastly, we have these 2 new affordable housing complexes coming online. The first may sound most familiar. That is Forest Point Place over off Arrowwood Road. This is the hotel conversion that the county purchased last year. We have 27 people living in that community right now. So the people that are living there now are people that were at our last COVID hotel. 2 people have since passed away. Since moving there, they're finishing renovations that we hope to have by June, and that will be really when it's at full capacity and that second building is built out, that this apartment building will be permanent supportive housing for people who are over 55 years old, who are literally homeless and have the most complex barriers preventing them from maintaining somewhere else. And so this is a partnership. Roof Above has been awarded the contract to provide that support services and operate the building, but it is a building that we own. So very excited about the success that we're already seeing there. And then again, because of the work that we're doing in our community as it relates to veteran homelessness, Community Solutions purchased Park at Ferentino, over in East Charlotte, that will provide affordable housing for veterans who are experiencing homelessness. And so there's just over 100 units will be set aside for veterans. They will be pulling people from our by name list. So this is because of the partnership, that they'll be able to take people that may have a HUD voucher or what they call an SSVF subsidy, a more short-term subsidy, or people that could pay a market rate, but they're going to take people in partnership with our continuum of care, our by name list, and these will be allocated specifically for veterans who are experiencing homelessness. And so they have purchased the building. Now these turnovers, it'll be through attrition. I think that was one of the things people worried, that everyone was going to be evicted and now it was going to be for this. That these are really units that through attrition that people in our community who are veterans will be able to access. And they have also, Community Solutions has also provided us funding to hire what we call a change agent or an innovative change agent to help us really address more systemic and system level work and helping us solve for veteran homelessness better. And so we're really excited. That position actually just started recently. And so we're already excited about the progress that they're doing. So we have a staff that is dedicated solely on working at the macro level on how we engage the VA and Livian and other veteran organizations and how we solve for veteran homelessness. And that, again, that is thanks to the partnership we have with Community Solutions. And with that ends my presentation. I think I'm pausing for the next presentation. Next.
Ms. Pelletier, thank you so very much for that phenomenal presentation. And we will certainly be asking you some questions shortly.
Absolutely.
We're going to call on our Deputy County Manager to introduce the Smith family. However, before he does that, we've been joined by a fellow commission member, Ms. Leek. If you introduce yourself for our visiting viewing audience, please.
Let me first say thank you. The name is Bill Hooley. I represent the most powerful district in the county, District 2, and welcome. It's good to hear what we're talking about, but we still have problems. Major problems in a big city like Charlotte.
Thank you very much. Mr. Trotman, if you introduce this last presentation, and then after that, commissioners will dive in with 3-minute rounds of questionings till we complete our questions. Mr. Trotman.
Yes, Commissioners, I'm proud to bring up Michelle Hunt and members of the Daymark team to provide an update on the community's first behavioral health urgent care. Funded by Mecklenburg County.
Funded by Mecklenburg.
Good afternoon. I'm Michelle Ivy. I'm the Chief Program Officer of Daymark Recovery Services. I have with me today Ashley Gold, who is our Senior Program Director for our Outpatient and Community-Based Crisis Services, and Michelle Hunt, Executive Director of the Smith Family Foundation. We appreciate you inviting us today to speak about the good work that is going on here in Mecklenburg County. We appreciate the support of the county commissioners, of Mr. Trotman, and of the community, and of course, of the foundation. Thank you so much. We opened a year ago tomorrow. March 20th of 2023 was the first day of services at the Smith Family BHUC. A little bit about who can present to the BHUC. It can be anyone over the age of 3. There's a little debate with the service definition, whether they have to be 4 or if they have to be 3, but it says over the age of 3. So usually as long as they're 3 and up, we can serve that person. And then anyone that needs a comprehensive clinical assessment, and we are open 24/7, 365. We're one of the few behavioral health urgent cares in North Carolina that are actually open 24 hours a day. Many of them only operate either 12 hours a day or 16 hours a day, but the one here in Mecklenburg County does operate 24 hours. Children may present to the BHUC, but they do need to have a parent or guardian to remain with them. We try to be as inclusive as possible. There are only a handful of people that we can't truly serve, but a person can be in the custody of law enforcement or EMS and come to the behavioral health urgent care. They may be voluntarily there. They may be there involuntarily. We can accept people under petition. A person may need detox. And we're payer blind, and that is where the county really comes into effect with the services we're able to provide. So we serve people who have no insurance, who have Medicaid, Medicare, who may have private insurance and are underinsured or may not have a insurance that covers a service such as behavioral health urgent care. So when you think about individuals who have a high deductible, may have an $8,000 deductible, $7,000 deductible, a lot of those individuals are not able to pay for that service. And so you think about what an emergency department visit would cost versus coming to the urgent care. It definitely makes it more feasible for that family or for that person. We do offer interpretation services, so we are able to accept anyone who speaks any language. The only folks that we cannot accept are folks who may have medical issues that are unaddressed, meaning a person who has uncontrolled hypertension, uncontrolled diabetes. If it's controlled, we can manage that person. Or if a person has an open wound of some kind, we may have to send them for proper medical care before accepting them. We frequently have individuals who have to receive medical care and then they can come back to us. That happens on a routine basis. And then individuals have to be generally cooperative. We can deal with a certain level of verbal escalation, but we are hands off. And so we are not able to restrain individuals. So a person does have to be relatively cooperative with us to engage in our services. Referral sources. We see a lot of individuals from a lot of different places all across the county. They may be referred by a school. We've had referrals from some of the local universities and colleges, social services, law enforcement, the justice system. That may be a court referral, a jail release, other behavioral health providers, Anuvia, McLeod. Those are common referrals that we may see. Hospitals, including the psychiatric emergency department here in Mecklenburg County, outpatient physical health providers. So someone's primary care provider may refer them to the BHUC. Human service agencies, such as food pantries, obviously our colleagues that work in housing definitely receive a lot of referrals from those sources. Alliance Behavioral Health, the MCO, the mobile crisis teams, and then also self-referral. A person can walk in and say, I need help, and we will take that person in. They do not have to be referred by a specific agency. As far as the services that are provided to a person in the BHUC, first and foremost, they receive a comprehensive clinical assessment. There are times that that assessment may not be as in-depth as others based on a person's ability to answer questions at that moment. They may have some level of intoxication, or the crisis may be such that they can't answer certain questions, or it's not appropriate to ask certain questions. But we do our best to ensure the best assessment possible given the person's current situation. They also receive a physical health screening. So we ask a person about any wounds, about any health conditions. Do they have unmet medical needs? And if they have unmet medical needs, how can we then link them to resources to meet those medical needs? Supportive interventions, that comes from our staff, who a lot of our staff have lived experience or are peer supports. And so being able to support that person, help that person work through the crisis at hand, and how do we then get that person to the most appropriate level of care? Therapeutic interventions from licensed clinical staff, as well as interventions from our nurse practitioner that is always on call. 24/7, we have a medical provider that is able to answer questions and to help us with the individuals that present to the BHUC. We help people with outside referrals, and that may be a lower level of care, a higher level of care, a primary care physician, intensive outpatient programs, inpatient care, residential treatment. So a number of behavioral health and physical health services, as well as assistance with referrals for housing, food pantries, assistance with applying for Medicaid through DSS, insurance information, or pharmacy assistance, helping someone get their medications. Sometimes that is a crisis. I can't get my meds. How can we help a person get their medication? And then we work to follow up with each person that's been discharged. We want to make sure that they have an appropriate appointment when they leave us, or an appropriate placement when they leave us. And then we follow up from there. This includes helping provide transportation. And that is something that the dollars received from the county helps provide, because that is not a reimbursable service under Medicaid or state funds. And so we're able to help that person get transportation, making sure that they can make it to the next needed level of care. As far as the numbers served, so we, again, started March 20th of last year, and from March until the end of June for the fiscal year, we served 554 persons during that time, and we were able to divert 493 of those individuals from the emergency department. We only had 49 people that had to go to an emergency department, but 37 of those were because they had a medical need that we could not meet. Typically, you will see someone coming in and their blood pressure is just way outside what it should be, and we're able to work with the local emergency departments to help that person be seen and to get them medication. We've established a very good relationship with those partners in the community, and they will give that person a small supply of their medication so that we can then help them get past that point and on to the next level of care. We did have 9 individuals that needed psychiatric hospitalization, and we were able to get them directly admitted without going through an emergency department. That can be very difficult to do. But we have been successful in doing that. We had 118 that were admitted to either facility-based crisis centers or detox units, and 366 were referred to community-based services. So a follow-up the next day with an outpatient provider, or a follow-up to be seen for SAIOP, substance abuse intensive outpatient program. So those were the types of services that you'll see those individuals referred to. So far this fiscal year through February, we have served 1,480 folks, and this number goes up every day. We have been extremely busy the last few months, especially. I know over the weekend I was on call, and I don't think there was any time that they had less than 7 people in the behavioral health urgent care. We can have up to 14. And so that was 7 people in the chair, and they had 3 being assessed. And so there were people kind of all over the building. We definitely have been busy. From the outcomes through February of this year, we've been able to divert 1,361 individuals from emergency departments. We did have 119 sent to the ED, but only 7 of those were due to psychiatric acuity. And I think that's an important notation, is that we're able to, through that physical health screening, determine, does this person need physical health first addressed, and get that addressed and then come back to us. And so when we send someone out, we always make that connection with the emergency department and let them know, yes, we can take this person back once their blood pressure is under control, or their diabetes is under control, or they have their seizure medicine, or whatever the case may be. 110 of those individuals have medical needs, but only twice were we not able to serve someone because we were at capacity. We are very efficient in how we move people through the behavioral health urgent care and are able to get people to the appropriate level of care. So even if we're at capacity right this moment, an hour, we probably won't be because we're able to use other resources to get folks into detox units or facility-based crisis centers. And I think that's an important key to what we do, so that there's not this backup of what's going on within the system. And as you all have, if you've spent any time in an emergency department, there's always a number of people waiting that have psychiatric needs. We try to prevent that from happening. 441 were admitted to facility-based crisis centers or detox centers. 5 were admitted to state facilities. And so this is something that can take a long time to get someone to a state facility if that's what's needed. And we're able to work with that person and work with the state facilities to get a person admitted and try to divert from the emergency department as much as possible. And then, of course, 892 of the citizens were referred to community-based services. And that's all I have in my presentation for today.
Well, fantastic. Are the other ladies going to?
I was just going to take a quick moment from the foundation side, just to kind of update everybody. As we do this in partnership, very close partnership with Daymark, the foundation, going into working on the BHUC was really responsible for getting the building up and running and getting the facility ready to go. Since then, we really work to be out in the community so that we can be doing some of the work that obviously Daymark being in the facility and being in terms of operating it, we can be out in the community to do the things that Commissioner Leek actually just spoke of, is that, while we're doing great work, we know there is a lot more that needs to be done. So the foundation is really taking this time now that we're operating, now that we have data almost a year later, to be able to specifically tell us what is needed and what we're seeing. We are working with other partners. We spend a lot of time talking with law enforcement and a lot of other organizations, community leaders to figure out what is the next step. A lot of individuals say, that's great, you've got a BHUC, what does next programming look like? Well, we are in a unique position with the foundation to be able to, while we're not operating and doing that legwork, we can be pulling all of our partners, all of our resources, all of the data together to be able to look ahead and say, and working with all of the departments, Mecklenburg County, to figure out what does next steps look like. So that is where the foundation at this point is spending the majority of our time, now that we feel good about having the facility and operating. What does next steps look like? So we will continue that work. We'll be continuing to reach out to others in the community, and then obviously staying in touch with everyone, specifically Mecklenburg County, to figure out what the next steps and what that next path looks like for expanding programming and what that looks like. So just wanted everybody to understand what the foundation's piece, how we are actively involved in what we're doing. And it wouldn't happen without obviously the county first, having Daymark to be able to do exactly what we were hoping and expecting that it would do. I think this data has shown, and what we see every day, it's doing that. But also understanding it's just a starting point. So thank you.
Thank you.
I do want to say one thing. I just want to thank the county in general. When we came in here, I am not from this county. I'm from Iredell. So I'm sorry. I'm sorry. I'm not from Mecklenburg, but when we came into Mecklenburg, it was amazing. The partnerships, the stakeholders, how welcoming everyone has just been amazing. And we are in multiple counties with Daymark, and it is not always that way. So just kudos and thank you to the county, all the stakeholders, because it's been amazing being here. Thank you.
Well, thank you very much for your presentations. I will go to my colleagues on the committee for questions. And let's start with behavioral health, since you ladies are already up there. But before we do that, we got a little housekeeping to do, since we have our quorum now that we can approve our minutes from our February meeting. Come back to our agenda and ask if there is a motion to adopt our minutes from the February meeting.
So move, Mr. Chairman.
Is there a second?
Second.
All right, any discussion? Hearing none. All those in favor say aye. Aye. Thank you very much. Now, let's go to some questions. I'll start with Commissioner Powell, then Commissioner Leak. And then after those questions with behavioral health, I'll ask our guest commissioner, Commissioner Rodriguez McDowell, if she may have a question or two. 3-minute rounds, ladies, please. Thank you.
Thank you for the presentations and the number of diversions from the hospitals because they are so overcrowded. But Commissioner Rodriguez McDowell and I were at a forum recently called Fractured, where they were talking about how many mentally ill people are incarcerated. So I'm thinking that, like, I just like to hear your experience on how many people you probably helped keep out of jail.
We often have jail diversions. A lot of the times when law enforcement brings us someone, and we can provide that data on how many law enforcement referrals we've had, very often it is diverting someone from the jail. So typically it's a person who has not acted in any violent way, but they are in a situation where they may be trespassing. We've had a situation with a younger individual that was trespassing, and they were able to bring them to us to divert them from going to jail. And we were actually able to work with that person and establish rapport with them and develop trust to try to get that person linked to housing. And so those are some examples of that. But there are a large number of people that we can divert from jail because they have somewhere to go, as long as they are not in a situation where there has been some type of violent activity.
Thank you for that. And someone mentioned in the presentation about sometimes it's a crisis when they can't get their medicine. And so I've had mothers call me about, I don't know why they think a county commissioner can get the medicine, but it's so urgent, they don't know who to call. How do we help with that from Mecklenburg County? Like, are we helping in that area?
So we don't have a pharmacy on site, but we are able to work with agencies such as NC Medicist, and then also working with individuals to help them apply for Medicaid to be able to get medications. We've had situations where we have been able to work with emergency departments to get them a small supply of medication. And so by having that relationship, allowing that person to pick up that medication from an emergency department, and then we link them to either a free pharmacy or something of that nature in the community is what we have been doing. And how Mecklenburg County assists with that is just providing those additional resources such as transportation to help that person get there. If we are able to say, okay, we've got your meds, you need to come here to pick them up, then we can help that person with the transportation, because it's usually a number of social determinants that are keeping that person from getting their medication.
Yes. And they were talking about that at the Fractured Forum about, the patients who don't think they need medicine, and then the families that are trying to support them by getting them the medicine. And so it seems like that would be such an important part of, responding to the needs and making sure they get it when a lot of people don't have a car. So thank you for that. And if there's something else that you think that we should know, just let us know.
All right, let me go to Commissioner Lee. Commissioner Lee.
Thank you. Thank you for the presentation. My concern is a multiplicity of agencies. How do we let this public know what we have available? And I talk about this all the time through social services and other agencies that we have. We're not affording the community to know all that we have. What we do offer and where they are located. And just Friday was opened a new health facility right there on the grounds of the YMCA on West Boulevard. Excellent facility. And they just opened it. So I'm hoping that as we look across this community, just about every other corner has a health corner. As in some counties, in some states, liquor stores are on every corner. So how do we get this information to the general public? That's number one. And number two, I'm concerned about the state role versus the local government role. We cannot finance ourselves out of this problem of health. This is one of our national issues, is healthcare. So how do we revert back to support from the state that we had at one time? Even the facilities was in Raleigh, most of them. And under the Republican administration, they closed all of those facilities and put people on the street. And that's what we are suffering from today. So we must have and hold elected officials accountable to take care of the people. And we're not doing it. We get these reports from you once a month. And after that, and there's no negative reflection on anybody. It's just a fact that nobody comes back and say, what have you done for me lately? What has changed? I asked about the social workers, was recognizing through a resolution 2 weeks ago, 3 weeks ago, of a month for them. And I've asked them to tell me, what are you going to do for our social workers for the month? And I have not heard one word as to what those items would be. If you're gonna provide lunch, you're gonna give them a break, whatever your decisions are, let the public know what we're doing to impact those who work with us and work for the community. I said it that night. And no negative, I'm not saying to be negative, I'm talking about a fact. When we put our resolutions, people read them every other month. And that's it, and then they go in the trash can, and that's the end of it.
All right, Commissioner Lee.
Salvation Army.
All right, let's give our presenters a chance to answer those two questions you had.
Well, I'm asking, so if I don't get a chance to answer them,
You will,
they will get back with me at some point.
you will. Go ahead, ladies.
In the case of the Smith Family BHUG, we have had a good amount of media attention, and that has to do a lot with the affiliation with the Steve Smith Family Foundation. We have provided interviews to local media outlets. The foundation has been very gracious in some of their outreach to individuals that they work with and to educate about this Smith Family BHUG. And so we're very grateful for that. And so we've had actually more marketing in Mecklenburg County than we probably have anywhere. As to the funding, so the funding, the BHUG receives funding from 3 sources, I guess technically 4. The county provides funding to help make up the difference for those who do not have a billable insurance or an insurance that won't pay for this service. We also receive state funding. We do follow the state service definition for the behavioral health urgent care, so we can bill for state funds, and then we can also bill Medicaid. So we have a contract with Alliance, and so the funding technically comes from those, or the bulk of the funding comes from those 3 sources, and then we also are a private nonprofit agency and can receive donations for the care of individuals that are coming to the BHUG. Does that answer your question?
If not, we'll get around to the second round. She'll get another chance to ask to follow up.
I'm just going to add one quick thing too. Commissioner Leek, just so you know, the piece that the foundation is also trying to do is, albeit it's going to take a lot more work, but getting out into the churches, meeting with, like, we were in the Greer Heights community and actually in the community, just trying to make residents aware. It's one thing to, just be on the billboard, but if we go to those communities to try to make them, or to make people aware of the facility and the services that we're providing, that is where we're trying to put our focus. The foundation staff is relatively small, but at least a beginning and starting work of actually trying to go within the communities to make individuals aware of the services that are available to them. It's just the starting point. There obviously is a lot of work that needs to be done, but at least trying to do a starting point there as well.
All right, I'll call on Commissioner Susan Rodriguez McDowell.
Thank you, Mr. Chairman. I just have a couple of questions. Y'all aren't the only ones, but I've heard other places that do not have pharmacies. And I'm just wondering, does that mean, you obviously probably are using you know, pharmaceuticals to help people? Like, does this just mean you can't provide them with some to take home? Is that what it means? Or does it mean you just don't use drugs at all?
We're able to give someone a prescription. We are not able to provide them with anything other than over the counters unless it's a prescription that they bring with them, the way a BHUC is designed, because it is not a licensed facility. There are some cases where there are behavioral health urgent cares that have pharmacies, but it is a very complicated process, and that's the reason that we do not have one here in Mecklenburg County.
Okay.
Because it requires you to have either a pharmacist on site at all times or not a nurse practitioner, but a physician, a licensed physician that has rights to actually dispense medication. And the pharmacy laws are very strict, and that's why we have talked about that a number of times with the county, but it has not happened here just because it is a funding issue for a
Okay,
pharmacy.
so just so I understand, that means if somebody comes to you, you can't give them any drugs.
We cannot give them, we don't have the ability to say, here is a pill for you to take that's a prescription. That's correct.
Okay, okay.
But we can help that person get to where they can. Our goal is to then link them to where they can get that medication.
Okay, so like you'll write them a prescription and tell them, hey, go get this filled and this will help you out.
Right. We'll provide them with transportation. We'll link them to somewhere that either is low cost or free of charge.
Okay, got it. Thank you. And then my other question was just about your capacity and, you know, do you have repeat clients or, you know, can you just sort of, with your numbers?
We can have 14 people at any time in observation. In addition to that, we do have 2 rooms that are private rooms for children that may be, so the total capacity is 16. We do see individuals that come back a number of times, and usually it's individuals that have a hard time engaging in ongoing services. So our goal is to work with them to get them engaged, and we've even gone so far as to then transport that person to their outpatient appointment. We have a younger person that we worked with that she came back to us a number of times, and she had a severe and persistent mental illness, and we were eventually able to gain her trust, get her into a stabilization program, and then actually get her started on a long-acting injectable through the use of samples that one of our outpatient clinics had. So we would transport her to the outpatient clinic. She would see the MD, and then the nurse there would give her her shot. And so those are some of the things that we've done with our folks who are coming in on a not routine basis, but semi-routine basis.
Okay, thank you.
You're welcome.
Thank you, Mr.
All right.
Chairman.
I'm going to ask a quick question, then we'll see if we got another 3-minute round, and then we'll go to the Ms. Pelletier's presentation. You indicated there was 542 your first 4 months and 1,480 the next 8 months. And if you average that out, it's about 135 your first 4 months and then 185 the second period. Is there a limit in terms of numbers of folks you can see a month? I mean, that's because you're increasing now. I don't know if you're going to max out at some point. And the other question would be your referrals on slide 4. You had a number of referral sources, and one of the questions that came at one of the commissioners was, where are you getting a lot of these referrals? The next time, can you disaggregate that on your census? You say we're getting 5 from the schools this period, we're getting 100 from the jails, we're getting such and such the next time you make a presentation. Those are my 2 questions.
Yes, absolutely. We can give you immigrant information on where referrals come from and how many from each source. As far as capacity is concerned, because a person can only stay up to 23 hours and 59 minutes, usually we move people along through our level of care pretty quickly. And we've only had 2 times that we've reached capacity because of that. So is it feasible that we could get to a place where we are no longer able to take anyone else? Yes, but it would be rare. And because of the way folks move through the level of care, it would not be for very long. So there may be a couple of hours that we're not able to accept someone, and we may have to divert individuals, but then we would be able to accept individuals. As far as our capacity at any given time, I think the average length of stay currently is between 5 and 6 hours. And so I think if you multiplied that times 16 times the number of days, and then take into consideration the 24-hour period, that would probably be our capacity. But we've not seen that, nor have we seen that happen in any of our other behavioral health urgent cares.
Let me ask my colleagues if they got like any hot button alibis for this round before we call on Ms. Pelletier. Commissioner Powell, you have a follow-up?
Just quickly, it's really on my mind, the fractured forum that we were at, because they had a movie where the mentally ill were featured, and they were talking about how much burden is put on the family, and the family can't take it anymore. And then to hear the average length of stay makes me wonder, like, about the touch points. Like, I think it's when they come in, they're embraced into this, into your or your facility. But how are you helping the support network? Like, talk a little bit about it versus like just on the paper. What is the support network after they leave?
The support network, if we have a resource in Mecklenburg County that we can link that person to, we will link them to that. If need be, we will take them there. If there is not a resource that we can access timely, we rely on our other 30 locations to see if we have a resource that we can provide that person with. Example is the lady that needed a long-acting injectable and did not have insurance. We actually linked her to our office in Cabarrus County, where we had a sample of that medication, took her, and she saw the doctor and the nurse and got her injectable. So we work with all the other county partners. So looking at your housing options. And so we will either take them there, try to do a warm handoff for that person to get them linked, because it's one thing for me to hand you a piece of paper and say, hey, go there. That doesn't work. But how can I do that warm handoff? Can I engage you with that person before you walk out the door here? So can we call this other group and have you speak with someone? And that way they know to be looking for you and engage with you and where to find you. Especially with our individuals that are unsheltered, working with those folks, where can we find you? Asking those questions and then providing that information to the next referral source. So if this person doesn't show up, this is typically where they are. This is how you can reach them. Or if they come back to us, we reach back out to them and say, hey, we have our person.
And I'll just add really quickly too, we're undertaking a behavioral health strategic planning process that I think I've referenced at some different public meetings we've had and some other board communication. We have convened a lot of stakeholders, and one of the key themes that's come out of that project is a real issue around coordination of care and people falling through the cracks, and even with families too. So it's all of these things that you're referencing from Fractured. We are preparing to finalize that plan and probably publish it for public comment in the next month to 6 weeks for, feedback from the community. Then we'll work on an implementation plan. And I would see a lot of the efforts to better coordinate care across providers and for families too, to be part of that implementation planning process. So it's a huge need, and we are aware of that and working on addressing that as best we can. It's complicated, but we do want to see some progress and some initial wins in that space.
Thank you. Let me go to Commissioner Leak for a quick follow-up, and then Commissioner Rodriguez McDowell, and then we'll get with Mrs. Pelletier real quick. Commissioner Leak?
I'm looking at the information pertaining to walk-ins, and especially to families and children. Clinical assessments and the violence that's going on in our community every morning when we wake up or before we go to bed. 2 or 3 people have been killed in this community. And to see that a family was found just this weekend in a home in this community. I'm concerned about our children, our men, and our women. And we're not seemingly reaching, it's not your problem, personally, please don't take it that way. But it grieves me that the violence in Mecklenburg County is not decreasing, but increasing. How and what can we do to help alleviate or decrease the major issue of violence in this community?
Is that a question for the ladies?
Yes, it is.
All righty.
They work in that department.
All righty.
I can give you my clinical opinion as a licensed clinician. We screen everyone for trauma. We screen everyone under something called adverse childhood experiences. And I think the key to reducing violence in our communities is that we need to provide preventative care, be involved with children as much as we can and their families to try to help their parents understand what it means to parent in such a way that we are not inflicting more trauma upon the next generation. And how we do that is through therapy. How we do that is through school programs. And like I said, this is just my clinical opinion. But it is a big problem, and it's not something that I know an all-inclusive answer to.
All right,
Appreciate your response. And I'm speaking from my district perspective. And that's why I'm bringing it up. It's a major problem. We talk about it. But how and what can we do to help to alleviate it? And I see here in the age
Commissioner Leek, we're gonna have to go to the next commission because we've run out of time for this one.
The board committee members would get a response quickly and move on.
We're gonna go to Susan Rodriguez McDowell. Yeah.
Thank you, Mr. Chairman. I just wanted to say thank you for what you do for the community. Thank you for also to Mr. Nesbitt here about the care, you know, the plan that you're working on, and just I really appreciate Commissioner Powell bringing up fractured and just all that we learned, and just about the toll that it takes on families. Like I really hear that you guys are working to, you know, kind of support people in ways that, you know, are just so necessary and so needed. And anyways, I just wanted to say thank you for the work that you do. I don't have any more questions. Thank you, Mr. Chairman.
All right, going to thank the Smith Family Behavioral Center for your presentation. And now if Ms. Pelletier can come up to the firing line. Thank you for your patience. I'll reverse it and start with Commissioner Leek for your questions for Ms. Pelletier with regard to her presentation on the.
I take up too much time.
You get your 3 minutes. All right.
Did I pass?
You pass? All right, Commissioner Powell.
Thank you for the presentation and for all of your work. And you know, you're in a loving environment. You said you know, the number one complaint is the time waited for a coordinated entry response. And that you're committed to calling everyone back within 24 hours. So I want you to talk a little bit about that, because you said you have some relief with the ARPA money. And do you need more relief? Because it probably is our number one complaint that we get. Because the people that need it, by the time they do call, feel like they are in crisis. And then when you get the recording, it's just a punch in the gut. And so if you speak to that.
I may defer some to the fabulous Megan Coffey on some of that, because this is an issue that she deals with every day. So interject wherever you see fit, Megan. I will say that I do believe that part of our budget ask this fiscal year is to maintain those ARPA funded positions, because because they're staying very busy. I don't know what the exact number of people that we need conducting coordinated entry to get that. That's one of the things we're trying to figure out with the call volume piece and how long it's taking, how long are we staying? Is there a way to shorten the length of time that we're on the phone with people, but still receive the same level of service and needs? So we are trying to figure that out, but we do know that it starts with at least maintaining what we have with county and ARPA funds throughout. The other trick to that, though, is we could have 100 people answering the phone and still know where to send people. So I just want to make sure that we don't I just want to make that clear as well, because even if we had 100, we don't have 100 beds today at Salvation Army. So it is this trick about how are we right sizing our homeless response that isn't just at coordinated entry. I don't know if that answered your question,
It
but I know
does.
that's something that we are really working to definitely improve. That's part of it, why we're training other community partners to conduct coordinated entry themselves. But it's that shelter capacity that still ends up being a barrier.
And so I do understand that. I just think as technology has moved forward in my lifetime,
Mhm.
and whenever there's an urgency and a human being doesn't answer
Yes,
and you're in crisis,
100%.
it's just makes it 100 times worse. So that even if a human being answered and just listened with some kind of empathy, might not have a place, but at least you answered. And so it really is important to me. That's why I brought it up.
Absolutely. And I don't know if Megan, if you have anything to add to that.
Well, I want to help. So
All right,
thank you.
Mhm.
Let me go to Rodriguez McDowell.
Thank you. Let's continue that because you ran out of time. Because I do agree with you that there would be nothing more beautiful than to be able to answer the phone with empathy. And so I would like to know also how many people would it take? You know, like how far short are we with having the resources to be able to make sure that we can answer the phone? I mean, I just really would love to know how we could fund that. You know, what it would take, even if there is no place to go that
Right.
get through to even hear that, you know, we're working on finding you a place, but we have nothing right now.
14 calls a month. It's 1,400 calls a month.
1,400.
Yes,
That's
1,400 calls
16,000
per month.
So how many number of people it takes to answer 16,000 calls?
How many is
We-
that? I don't know.
We need to work on a comprehensive call center strategy because this is a subset of the number of calls that we get for multiple reasons within the county. I'm looking at Yolanda and the economic services calls for food nutrition services and some of these other programs. So I'm working with IT now because most of these departments, transportation, public health, all have call centers. And we have to like look at things very differently. The world is shifting to more AI for some of the more basic calls for some of the more sophisticated customers. If we can like shift some of the calls that, you know, for quick interactions and then use our social workers, caseworkers and others to deal with some of these more complex calls, but they're dealing with everything. So people that call coordinated entry, it could be something simple, or it can be an hour-long interview.
Absolutely.
So this is part of the issue that we're dealing with.
I really appreciate your answer because the idea of trying to combine is what I hear you saying, trying to combine many different areas that need call centers and to maybe make a comprehensive call center that can handle everything. Is that kind of what you're saying?
Yeah, I mean, we in HHS, we had an initial strategy to do that. And so the LB Scarborough Center actually had space in it for a comprehensive call center. There was some shifts in policies. So we shifted away from that and we shut down our Charlotte East locations. The place is full now. We're using every inch of the building. But we definitely need to go back to this call center strategy because it is difficult for us to keep up with the volume.
Thank you.
All right, let me just ask make a comment. I want to thank you for pulling people off the corners. That's just phenomenal in terms of the county's ability to do that. I'm not sure what the end result's going to be, but I think that's just phenomenal. So keep doing that work. The program that's at the libraries on certain days during the week that provides free showers and toilet services and handing out materials. That's just godsend in terms of those folk who are working with people who absolutely out there on the block. My question is about the park at Ferentino. Can you speak a little bit more about that? That's first, maybe you've said that and I've missed that, but that's the first time I've heard that.
Absolutely. And so the Park in Ferentino is an apartment complex that Community Solutions, our national nonprofit, purchased in East Charlotte. I think it's off Monroe Road down that way. And it is, there's zero county investment in that and financially. However, we are a partner in them and helping to find their residents, so to speak. So as units turn over through attrition and people decide not to renew, that they'll reach out to our, what we call our Housing Our Heroes, which is our veteran homeless work group, and kind of see who's next in line, who wants to live there. And there's no barriers to that. So we'll take people that are just from our veteran by name list. So that's our list of veterans that we have experiencing homelessness in our community. And so people, because we know we have 40 veterans in our community approximately that have a HUD-VASH voucher, which is that permanent subsidy, but they can't find a landlord. So this will help people who have subsidies but can't find that landlord, or could pay market rate, but still can't find a landlord because of other barriers. So they'll reduce some of those barriers regarding credit, things like that, and then be able to provide housing for them.
In addition to the aged out kids out of foster care, are we providing wraparound services with Accent Housing or just housing?
Both. So the relatives has that contract and they're doing that wraparound service. They're meeting with the links worker with Youth and Family Services, developing those housing plans. And then they're in those units every week working on them, on trying to help them develop skills, get acclimated to being an adult, whatever that may mean at 18 and 19. And then helping them maintain housing long-term.
Let me go to my commissioners. We got about 8 minutes left before 2:30. Witching hour. Is there like a minute question or something you might be able to ask and get an answer?
I want to dive in now if you don't mind.
All right, Commissioner
I
Powell.
Oh, you said Powell.
Oh, no, okay, I thought you would, go ahead. Commissioner Lee, go ahead.
Okay, all right.
Go right ahead.
I've gotten several, not 2, but 12 concerns about the public library being used as a site for health purposes, bathroom, and the time that cleanup comes in to satisfy the people who are there to use the library can't use it because it's not clean. It's used otherwise. So we're advocating that we use the library as a site for healthcare. That
No.
should not be.
No, there was a mobile bathroom there, not a site for healthcare.
I'm saying what was said to me
Oh.
on Saturday
Okay. Yeah.
about the use of the library being cleaned up and not cleaned up because of filth.
Yeah.
The use of the bathrooms, not using the bathrooms appropriately. And to hear you say here that that's what they're doing.
I'm saying that there is a program where they have a big old trailer, like a tractor trailer, that has a bathroom and showers in it.
Which library you making reference to?
They rotate. One's at Beatty's Ford, they rotate over out at the university. And so there is like a trailer. They don't go inside of the library at all with this group now.
No, I'm making reference to people using the library itself for health reasons.
Oh, okay, well,
And I had 12 calls on Saturday about the one on Beatty's Wood Road. And that's unhealthy for children and for families. So if that's what we're doing, we need to stop that.
yeah, we're not a part of that, Dr. Lee.
Well, I didn't know.
Yeah, we're not a
I'm just
part of
telling
that.
you.
Yeah.
So I'm speaking to it as their representative.
We appreciate that. Commissioner Powell.
Thank you. This is real quick. On the programs for housing stability with the aged out youth and domestic violence, you said that, if I heard it right, that for 2 years they didn't have to pay rent. Is that correct?
For the aged out youth program, what the First Place for Youth, who's helping us establish this program, what they say works best is allowing for those 2 years for the young adults to save. So they're either using part of their voluntary placement agreement money that they receive as part of being an emancipated youth, or from their income. They're able to save that portion. And the subsidy that they receive that we have with the relatives, they're providing that rent payment.
So is Mecklenburg County providing the subsidies for?
Yes.
Okay. And for the domestic violence one, because you got the answer on, were they getting wraparound services on that? So for domestic violence, how is that rent? How are we doing the subsidies for that?
So the Housing for Good program is fully funded by the county, and that's a subsidy for 2 years. And we have a staff member that provides those support services. So it's what we call rapid rehousing. So it's that subsidy and support. And then for our HUD funded program is similar, but HUD pays the subsidy and pays for that case manager.
And so there's a prioritization process. I'm very interested to know how many people you have to prioritize. If 15 plus 16 are getting it, we know the need is great, a lot bigger. So who got bumped out? I would love to know the numbers.
I could give you that. We just did our data migration. We know that we have over 3,300 people in our community who are experiencing homelessness. Of that, I don't have the data in front of me that are families. And then of that, this would be the families fleeing domestic violence. We do know that our domestic violence coordinated entry social worker has worked since October with over 100 families on helping them transition. Because right now in our community, when you leave Safe Alliance, if you don't have housing, you're going to Salvation Army. And so really what we're trying to figure out is how to reduce that trauma and stress and have another option for people. But we know that it's in the hundreds.
Yeah, if you could get that information back
Absolutely.
for Commissioner Powell, I think she'd appreciate that.
Absolutely.
Ms. Rodriguez McDowell, you got a quick 30-second? All righty, now let me turn to the person of the hour, our Deputy County Manager. Thank you so very much.
Thank you so much.
Excellent work in terms of out there, particularly pulling people off the corners. That is tough work. It is tough. Your team. No, thank you. Mr. Trotman, any parting information for us administratively, sir?
Some of the information that we're doing, in addition to what Karen said, was shared at the budget retreat in partnership with the United Way. And there was a budget ask that was shared with the board at that time. And we'll come back with a more comprehensive update as well, because we think that's important. In addition to information that was shared from the Smith Family Foundation, they said 441 individuals were admitted to a facility-based crisis center or a detox center such as Anuvia. As you know or may be aware, we are opening our first facility-based crisis center here for adults, working with Alliance. We received a special allocation from the state of about $12.5 million in ARPA funds, and we had to add some additional dollars to that to realize it. The location will be at the site where our morgue is. We own land over there, and so there's no connection. The county owns some land in that area. So. And then we're working with StarMed as they open up a facility-based crisis center for children. So our community continues to expand in our service offerings in the behavioral health space.
Thank you very much, sir, for the update. Appreciate that. As I said earlier, this was going to be an interesting presentation, and certainly as evidenced by the questions and continued interest in both of the topics in terms of mental health as well as our homelessness. So with that said, is there a motion that we adjourn?
So moved.
Is there a second? No second? Well, I'll go back to Robert's Rules of Order. Once you completed your agenda, you can automatically adjourn. Yeah.